today another Slovenian. Slovenian, when they prepare to come on the Adriatic Sea, they don't stop. So I'm very privileged to introduce you to Professor Martina Drevenšek, who is the head of the clinic, orthodontal clinic at the University Clinical Center in Ljubljana, and professor of orthodontics at their medical faculty. And the topic of the lecture will be the role of orthodontists in preparing patients for orthognathic surgery. In Ljubljana, they have very good and long experience with treating such patients. In fact, the best maxillofacial surgeon in the region, meaning XU, is located in Slovenia, in Ljubljana, Professor Nataša Hren. Next year, in May, we will have a big symposium that would be focused on orthognathic surgery as a treatment option for patients with skeletal deformities and facial asymmetries. And the keynote speaker will be Professor Nataša Hren. And I hope also that Martina will come and also have a lecture on this symposium. So keep in mind, Alpe Adria in May, at the end of May next year, 2 days. It will be 2 days. Thank you.
Thank you, Professor Spal, so much. It's really a pleasure for me here. I know Riga. I spent 2 months at the Department of Orthodontics in Riga, and I was inspired by Professor Spal and his team. So glad to be here, and I would like to greet you in the name of University Medical Center. I work there as an orthodontist. My clinical interests are cleft and syndromes, and also orthognathic surgery, and I'm also employed at the Faculty of Medicine. And my main research topic is unfortunately biology of tooth movement, and actually nobody is interested. And I was glad that Professor Spal recommended orthognathic surgery instead of orthodontic tooth movement. Orthodontist has an important role in orthognathic surgery or a combined orthodontic surgery treatment. Actually, because here are no surgeons, we are the bosses of the treatment. We say if there is indication, and we guide the patient from the beginning till the end. But don't tell surgeons about this statement, which I believe very strong.
It isn't working?
It should be working.
No?
It was working.
Maybe there is a switch on-off on
Maybe.
the... Check it. Now?
Before it worked?
So it's a pointer? Yes.
No, you have to point here. Here.
Yeah.
A ja sam ga ovdje uštekala, čekajte, može da ga naptu.
A prije radio?
Nije radio.
Bom ja.
Oh no. There is a no. On. Now. Try now. Still not operating.
Perhaps battery is low.
It is a new one. No,
There's no
it
way.
isn't working.
And even on computer it doesn't work. It works with the mouse. I will do it with the mouse. So this is a very short summary how we can treat especially skeletal malocclusions. We think or we aim to do also the growth modification in skeletal malocclusions in sagittal plane, vertical plane, transversal plane. But we have to admit that if the skeletal malocclusion is moderate or severe, we are not very successful. I don't want to destroy your dreams because you are in the beginning of orthodontic way. But there are quite limitations of growth modification, especially in vertical plane and also in sagittal and transverse plane. We know that which appliances at what time are the most efficient, but still usually we do camouflage treatment in moderate and in severe malocclusions. Of course, I'm not against early treatment with growth modification. We do it with functional appliances. In class 2 treatment, we do it with functional appliances and skeletal anchorage in class 3 treatment. Because sometimes we are successful because it's so difficult to predict the growth. We cannot predict it very exactly. And if the growth is favored, we are successful in first phase treatment. But if the growth is not on our side, still the skeletal malocclusion is less at the end of growth, and orthognathic surgery is not so complex and stability is better. So we do early treatment, but with knowing its limitation. And one of the minus of growth modification therapy is, of course, long treatment duration. There are some orthodontists who want to be very effective. Some of them are more, they more think in a very logical way. And of course, it depends only on money. In Slovenia, all orthodontic treatment is covered by insurance companies, so we can do also first phase and second phase treatment.
Not all. You also have indices.
Indices, but only very light malocclusions are out of the insurance company schema. So for me, it's so difficult to talk about growth modification because especially in vertical dimension. This is one patient where we were very successful, but actually it was not skeletal malocclusion. It was forced anterior crossbite, and we did it at the age of 5. The treatment was very simple. We put the Frankel 3 appliance. We could do some other appliances, and when all permanent teeth erupted, we put the fixed appliance and finish the treatment. It was an easy treatment, and it was not skeletal malocclusion. It was only dental malocclusion. And this was not growth. We could talk about growth modification because if we didn't perform treatment at that time, the growth would be different. So in that way, we can talk about growth modification, but not about treatment of skeletal malocclusion. Sometimes we do it with bone anchorage, with skeletal anchorage, especially in class 3. We haven't started to do the skeletal anchorage in class 2. We started later. With functional appliances, we started at T is 1 or T is 2. You are familiar with this method. But if we treat with skeletal anchorage, we do it just before the peak of pubertal growth, if we manage to do. And it's very nice and very recommendable if we put the skeletal anchorage, if there is skeletal anchorage plates or mini implants, also during puberty growth, because so we can control the growth of mandible. Of course, there can be some surprises in unfavorable growth, especially in vertical types. And we know that the mandible in class 3 grows more and longer, so you never know what to do. And this is one of the cases which was successful, even if he was a right-angle case. Because as in all treatments, it doesn't help if the patient has vertical growth pattern, not in class 2 and not in class 3 treatment. These are very old pictures when I was very young, when I started with orthodontics. The early treatment was very popular at that time. We put everything to her. We put first the layer mask, face mask, we put her Frankel appliance, fixed appliance, and of course we were not successful. The growth went on and on and on.
You tried everything.
We tried almost everything, even chin cap. I don't know if there are pictures, because our professor was really tough. We had to do everything. But I would We all have not only good patients, successful patients. Sometimes it's difficult to show. Even later there were some unsuccessful cases. So, but fortunately there are not so many pictures. Most of our work in orthodontics is camouflage treatment. We do movements of the teeth and we camouflage the skeletal relationship of maxilla and mandible. And this is possible in mild or severe skeletal malocclusions, or if the malocclusion is only dentoalveolar. And most of our job is camouflage treatment. And this is one of successful camouflage treatment without extractions. Sometimes we do the extractions because sometimes it's easier to move the teeth if we have instructions. I would like to tell you that orthognathic treatment is easier than camouflage treatment. It's much easier. You just have to decide on the right time at the beginning, before the treatment, to do orthognathic treatment or camouflage. But when you start, for the orthodontist, it's much easier because it's much more predictable. There are not very clear criteria when do we perform orthognathic surgery. It's not, for example, width value is less than -7 millimeters, or width value is greater than +6 millimeters. No, there are some thoughts or some recommendations when to start the orthognathic treatment. There are some papers about it, but not very strict criteria at all. And most of the studies were retrospective, so they studied the cases when orthognathic treatment was performed. And you will see also in the cases in our presentation today that the criteria were very different. Most of the patients decided to have an orthognathic surgery or treatment because of functional problems. This is not the guy on the slide. He had no problems. He could chew, he could eat, think. He just had speech problems, but he didn't admit. His tongue. No, I say, I'm okay. I'm okay. And I asked him, how do you feel? How you look? No, I look perfect. I said, yes, you look perfect. He was very tall, and I said, I can eat, you can see me, I'm a strong guy. I really don't want to have orthognathic surgery. And then I went with him to Professor Natasha Ihan, and orthognathic surgery was performed. You cannot be like this, you cannot chew, we have to do it. So we did the orthognathic surgery and we were very successful. We even extracted some teeth because I will tell you later why. And this is the lady. This is the lady with a very strong chief complaint about her mandible, about the shape of her mandible. She said, I don't like my mandible, I don't like the retrusion of my lower teeth, I look ugly. We all know, there are a lot of studies, that the objective measurements of malocclusion, of skeletal malocclusions or functional malocclusions or appearance, they do not correlate with the feelings of the patient. This lady was feeling much worse than the boy I showed you before. And it was amazing. She really did a hard time to me. Yes, I would like to have an operation. I heard that the operation is possible. And I found the surgeon who was interested in this case because it's very difficult to operate such easy cases because the differences, the changes are so small. There is one clinical paper, criteria for orthognathic surgery, but it's very nice to read it. You can find it very easy on internet, but it will not help you when you have a patient and when you want to decide if this is orthognathic patient or not. Perhaps I'm a little too intuitive type of an orthodontist, but still I expect the data, I expect the studies. But anyway, it's difficult to decide when the case is orthognathic and when the case is camouflage. And here you all know these indications when to do the orthognathic surgery. For example, in cleft patients, we performed orthognathic surgery even if the subject overjet is -1 millimeter. It would be easy to camouflage the dentition, no problem. But the appearance is better when we move maxilla forward, because in cleft patients there is thinner upper lip, there is less elasticity in upper lip, and even the width is -4. We do the combined surgery. Yes. And unfortunately, I have only 2 patients where we did orthognathic surgery because of sleep apnea. It's not so popular in Slovenia to treat orthognathically.
But I believe that sleep apnea is not one of the criteria that is suggested by even this new index from Susan Cunningham, index of orthognathic functional treatment needs. So the sleep apnea is on the lowest point, so it will not resolve the majority of problems in patients.
No, because there are so many different, the etiology is so different. But in these 2 patients, the morphology, it was very retrognatic patients. And it's very useful to spend more time before we decide to do the orthognathic treatment. Usually we take the records and then we make a treatment plan, but in orthognathic patients we do it twice. We sit at least twice or 3 times because we have to tell the patients the procedures, we have to know the main chief complaint, we have to know if the patient agrees with the treatment. In this patient we needed half of the year to start the treatment. Of course, I never say you have to do it. You can't say, I can recommend you, it would be okay for you, you will have in the future less problems. And of course, you cannot say if you do the orthognathic surgery, there will be no TMD or TM disorders. So we just can say if you do orthognathic surgery, there is less risk to have TMD later on. So we look patients from all sides, especially when talking, when smiling. So we usually also perform video clips. And for me, it's much more easier to look at the pictures than to look at the 3D scans of the face, even if this is very popular at the moment. This is a plan. I have to finish at 2.
Yeah. Take your time.
Okay.
The lunch will be ready for us.
Great. Sometimes the patient comes to surgeon at first. Sometimes he or she comes to orthodontist to the first consultation. But as I told you, there is always orthodontist who decides if the patient is orthognatic or not. Of course, we have to consult a maxillofacial surgeon if she or he agrees with the treatment, if she sees any limitations of the treatment. But and if the patient is so borderline patients, we have to discuss with surgeon why we decided or why we would like to perform the treatment. And then the patient is prepared by orthodontist, and when orthodontists think that the patient is ready, we go again together to the surgeon. Sometimes I take 5 impressions of dental cast of upper and lower arch to see if the future occlusion is okay. Sometimes it goes much faster. And I'm always very sad because when the surgeon set the date of operation before the patient is ready, and then the surgeons are very busy and it's so difficult to postpone the operation. Sometimes I'm also, the treatment doesn't progress so quickly. Sometimes I think that I will have enough 1.5 years, but it's not. I need 2 or more years. And it's very important that the patient, after the surgery in our clinic, the patient stays in hospital for 4 days, 5 days. And when the patient goes home, it's very important to see the orthodontist at the same day, because we have to check the intermaxillary immobilization if it is in the right direction or not. If everything is okay, then it doesn't matter. But if everything is not okay, if the occlusion after the surgery is not perfect, we can do a lot with intermaxillary elastics immediately after the treatment. After 4 weeks after the surgery, we can start to do finishing of the case. And there is retention, and this is the whole story, what to do in retention period in orthognathic surgery patients. When to do treatment, it's difficult to say. We cannot do it before the growth stops. When does the growth stop? We don't know. We know approximately when the transverse growth stop. We know approximately when the sagittal growth stop. But even in class 3 patient, there are many studies which show that the growth of mandible is longer and the growth is more pronounced in class 3 patients. So if the patient is in CS6 stage, it doesn't mean that the growth is ended. So in class 2 patients, we can perform surgery earlier. In girls, we perform surgery earlier. And if the patient is not severe high angle case. If the patient is severe high angle case, we have to wait longer, because we know that the growth in vertical plane is the longest one. In clinical practice, we ask patient to measure in height, to do the measurements of his height every month, and if the patient doesn't, if his height doesn't increase more than 5 millimeters in 6 months, we can start the orthodontic preparation. And we still have 1 or 2 years to go. So this is one very important point to determine if the growth is almost finished. There are a lot of things going on in orthognathic surgery. Surgery first is very, or was very popular, because you get faster aesthetic effect, and the orthodontic tooth movement after the surgery is faster because of all inflammation going on. But still, the prediction of surgery, it's much more difficult, because you have to take into account what will you do with tooth movement after the surgery. We did it in this patient. Surgeons decided to do it, and I got the patient after surgery, and I didn't actually know exactly what to do. But there are some cases where surgery first is a very useful method, especially when there is not so much decompensation of upper and lower frontal teeth needed afterwards. 3D technology is also very popular in orthognathic surgery. We do CBCT scans only in asymmetry cases. And we usually print the model, plastic model, and then to perform first surgery on the cast of the skeletal bones of the head, but then we do it clinically. But in class 2 or class 3 cases or vertical cases, we do not perform CBCT scans. But it depends on the country, it depends on the philosophy of X-ray. In the States, everybody takes CBCT for everything. and some private offices in Ljubljana too. Before you sit on the table, first CBCT scan of upper and lower jaw, and then let's go. We started to do 3D with the help of 3D technology splints. We print them, but at the moment we are in the progress of doing it, not for all patients. Diagnosis is like in other cases, only as I told you, in asymmetry cases we do CBCT scans. History, we are interested also in previous orthodontic treatment. We also ask if there is any component of inheritance, especially to determine the moment when we start the preparation, because in real class 3 patients, if there is parents with the same malocclusion or some other relatives, we have to wait longer. It's difficult to control the growth. Usually we do a standard set of photographies in natural head position, left and right profile also. We do all the measurements. If there is no asymmetry, the lateral cephalogram is okay. Classical analysis. But in orthognathic surgery, we are very interested in the inclination of upper incisors to nasal line and on the inclination of lower incisors to mandibular line. We don't care so much about +1 to NA or -1 to NB, but we have to take into account the inclination to jaw lines. In upper jaw this is nasal line, but in lower jaw this is mandibular line. But if the case is difficult, if the soft tissue is or too strong or too thin to our opinion, we do the Arnett analysis. It's quite difficult analysis, and the cephalogram should be taken in natural head posture. And sometimes, I don't know, this is quite an easy thing, but sometimes it's so difficult to discuss with X-ray technicians to do the natural head posture, then you say, come on, we'll not do it. And we keep in mind the soft tissue analysis, the thickness of upper lip, the thickness of lower lip. It's very important when we predict the movements of the jaws. We do the length of facial structures, and this is very important. To do the measurements of relationship of soft tissues to true vertical line. And true vertical line is the line which goes perpendicular to the bottom, to the true horizontal line, but of course the patients, the cephalogram must be taken in natural head posture. And then we know where is the biggest mistake in soft tissues, because soft tissues matter the most. Of course, we analyze skeletal relationship, we analyze bone relationship, but we have to analyze also soft tissue relationships. And aesthetic line measurements to aesthetic line and nasolabial angle are not enough to plan the orthognathic treatment. How does it look like in reality? It's very important to plan combined treatment before the start. Perhaps this is very easy statement to start the procedures, but still it has happened to me sometimes that I decided to do the camouflage treatment, and then, I don't know, after a year I realized that it didn't work, and if there were no extraction, I could go on with orthognathic surgery. but in extraction cases, it's difficult to switch from camouflage treatment to orthognathic treatment. So it's very important that we know before the start of the treatment that we perform orthognathic treatment. And I have to tell you that it's much easier to perform orthognathic treatment than camouflage treatment in moderate and severe skeletal malocclusions. Sometimes people think that orthognathic treatment is shorter than camouflage treatment, and this is not true. This is not true. Pre-surgical orthodontics usually takes place for 1 year or 2 years or even 2.5 years if there are some difficult extractions. After preparation, there is surgery. This is discussed by a surgeon and also decided by the surgeon what surgery would be performed on the patient. In Slovenia, it's not quite common to do segmental techniques. Usually we do the 4-1 in upper jaw. We move forward to backward the maxilla, and bilateral sagittal split osteotomy, sometimes asymmetrical in lower jaw. And after surgery, it usually takes 6 months to 1 year to finish the treatment. If everything is perfect, if patient is well prepared, if the surgery went well, then it took perhaps 6 months to end the treatment. But if the occlusion after the surgery is not perfect, sometimes we need 1 year to finish the case. And patients are really tired of treatment after the surgery. They want to have their braces off. They want to disappear from our clinic, because even if they are told everything about the procedure, some of the patients have difficulties to cope with. What we do in preparation for orthognathic surgery. The first sentence is very important. We have to move the teeth in the different directions, in all 3 directions, to allow upper and lower jaw to be put in a correct position after the surgery. So in orthodontic preparation, we just do the teeth movement. We don't want to move jaws at all. We just do the tooth movement. And as I told you before, all orthodontic tooth movement should be planned before the treatment. And we have to take account also the relapse after the surgery. For example, if we do have an open bite, we are not allowed to extrude the teeth, the upper frontal teeth or the lower frontal teeth before the surgery, because if we do it, there will be relapse of extrusion and the bite will open again. Or when there is a cross bite, we are not allowed to tip the buccal teeth, just to tip them, because there will be relapse of the position of the teeth, and the result after the surgery will not be stable. For example, this is the case where the transversal discrepancy was quite big. In the anterior width, there was 8 millimeters of difference, but in the region of first molars, the difference was 6 millimeters between the upper and lower intermolar width. And this is too much to do with, I don't know, quad helix or to do it with rapid maxillary expansion. And before the orthognathic surgery, we performed also the SARPE, surgically assisted palatal expansion. Now the lady is being prepared for orthognathic procedures. And of course, it will take us 3 years to prepare her, not 1 or 2 years. Before the surgery, there must be extractions of wisdom teeth at least 4 months before, especially bilateral or asymmetrical mandibular split osteotomy. And there are some extractions of first or second premolar when we would like to compensate the inclination of upper and lower incisors. Perhaps if there is a protrusion of upper incisors in class 3, we have to put them into the right position according to the nasal line, and we have to do extraction, for example, of upper first premolar. We do align the arches, we do coordinate the arches, but coordination of the arches, full closure of the spaces, sometimes also the leveling over the arches are not must things to do before the surgery. In some cases, leveling has to be done, in some cases not. Of course, some small spaces can be left before the surgery because they can be easily closed after the surgery. But extraction of wisdom teeth, decompensation of the dentition, and alignment of arches should be done before treatment. It happens to me only once that the patient had a date for orthognathic surgery. She came with her luggage to her Anshan, and we realized that wisdom teeth were in the mandible. And we told the lady, yes, sorry, today we will do the extraction, and in 4 or 5 months you will have the surgery. She was divorced, she had to organize looking after her children, so I wanted to sublimate into the space. But unfortunately she took it quite okay. Quite okay.
Because then she had the time for herself.
Yes.
Somebody took for the children.
This is true. I would be happy if something happens to me. No. So from that time on, I'm very careful about wisdom teeth. As I told you, it's very important to do the right inclination of upper incisors to nasal line and inclination of lower incisors to mandibular line. This is how we do the decompensation. This is the lady I showed you at the beginning. Her skeletal malocclusion was moderate. There was quite big compensation. It means that lower incisors were retro-inclined to get a good contact with upper teeth. And before the surgery, to make possible the surgical movement of lower jaw backwards, we have to decompensate the inclination of lower incisors. And it didn't go smoothly. Of course, first we raised the bite to allow them to move forward. They didn't want to move. We could use class 2 elastics in this case, but in this case we use such a help of appliance to protrude lower incisors. We check the position of the incisors on the lateral cephalograms, because only on the lateral cephalograms we can say, yes, there is enough compensation there, or there is not enough. We have to do it. It's not easy, or it's not possible to do the analysis in the mouse or on the scale, on the staticas. We have to do cephalograms, and where we check the inclination of upper and lower incisors. And sometimes we have to do it twice, sometimes we have to do it 3 times. If everything goes smoothly, we do it only once before the surgery, but usually it doesn't go smoothly. This is the beginning. First, we started to do the preparation without the extraction, and this was a mistake. After the checking the inclination of incisors, it was seen even clinically. You don't need to have an X-ray, but we did it, and there was a protrusion, strong protrusions of upper incisors, and we decided to extract the first premolars to do the right inclination. And we checked it again before the surgery, and this is the X-ray after surgery. I just wanted to show that mistakes in treatment planning can be done, but sometimes they
even for professors.
Yes, yes, but this is life. I thought yes, it would be okay. No, but it was not okay. This is also decompensation E class 3 treatment, and we did the extraction in upper jaw to retroot upper incisors, and beside the extractions we also use class 2 elastics, and they help to retroot upper incisors and to protrude lower incisors. It's quite funny to put to class 3 patients class 2 elastics, but it works. And this is the patients after the completion of the treatment. This is finishing after the surgery. Here everything was perfect. Sometimes it's not so perfect. Here the elastics were worn just to stabilize the occlusion. Sometimes, especially young surgeons claim, oh, it's not need to, if everything is performed correctly during the surgery, you don't need post-op elastics, because they do stability with plates or with screws. But we do post-op immobilization with intermaxillary elastics in all cases for 4 weeks, 24 hours per day. Closing spaces, coordinating arches and leveling sometimes is not obligatory before the surgery. For example, what we do in class 2 patients, of course the preparation is different in class 2 patients or in class 3 patients or only in high angle patients. It's in class 2 patients, we usually have a protrusion of lower incisors to compensate the occlusion. And in class 2 patients, in high angle cases or in low angle cases, we perform the extractions of lower first premolars. And in high angle cases, we also do the leveling of the arches, because then the occlusion after the OP is almost done. We have to plan the target value of incisor inclinations. Of course, it's easy to say we will do the decompensation for 15 degrees. For me, I never set the number, because there is biology of tooth movements, there are different reactions to different mechanics, and even the mechanics is the same. If the protrusion is the same, the answer to tooth movement are different. But we are close to what we want at the end of preparation. If there is class 2 low angle patients, leveling is better to do leveling after the surgery, because raising of the bite is much easier to perform after the surgery. So we did segmental leveling of frontal teeth and lower teeth, but we do not perform the leveling of speaker in lower jaw and in upper jaw, because
neither in the upper. So you don't level the reverse curve of the spine.
It depends on the curve of Spee in upper and lower jaw, but usually the curve is much more pronounced in lower jaw. And then after the surgery, we raise the bite, yes, with leveling of speaker, with intermaxillary elastics, not only with reverse speaker arches. But it's again the tradition that we operate much more class 3 patients than class 2. In Slovenia, the class 2 is much more accepted also in males, not only in females. In females it's almost nicer to have class 2, but we would like to change it also to operate some class 2 patients. Gummy smile is getting quite popular too.
Really?
Yes.
And ectopic canines?
No. when I was young, before my upper lip became longer, I had really a bad gummy smile. In all my pictures when I was in primary and secondary school, I was smiling like this. Now it's just perfect. At the age of 15,
You're just perfect now.
I needed to wait quite a while. That's why I told when I see the gummy smile at young patient, we have to treat it. We have to treat it. You can't walk around with gummy smile. No, I'm a little bit more polite, but I think, as I told you, in class 3, this is class 3, sorry because it's not seen on the screen. In class 3, we usually, if needed, we extract upper first premolars. Sometimes, of course, we do extractions in both arches. Some of the clinicians recommend to do extractions only in upper jaw. Some of them recommend to do extractions of first premolars in upper jaw and second premolar in lower jaw. In latter case, you get much more stable occlusion because if the extractions are performed in both arches. Then we decompensate, use class 2, not in all cases, and usually expansion is needed of upper arch, but it is needed also in class 2 patients, not only in class 3. And what expansions we choose, it depends on the discrepancy in transversal plane. Sometimes we do quad helix, sometimes we do rapid maxillary expansions, and sometimes we do sulfate. It's very important that before surgery, very strong arch wires are in place to do the stabilization of the dentition, and they also use for post-op immobilization. It's quite a big mistake if we put an active arch wire, for example, 4 weeks before the surgery, because then the splint don't fit, the splints don't fit, and also after during the immobilizations there are tooth movement and the occlusion is not perfect afterwards. Records before surgery, we do study casts. The surgeon mounts study cast with space bow, especially in bimaxillary surgery and when there is the 4-1 surgery. But if there is only surgery in lower jaw, it's not needed. We do radiographs, panoramic X-ray to check the position of the roots, to check the level of the alveolar bone, to check the joints, and to check if there are wisdom teeth in the mouth. We do PA cephalograms, but in asymmetrical case, but it's much easier to do CBCT scan of whole face in a symmetrical case. For me, it's very difficult to do the analysis of PA ceps. I don't know. Sometimes I just decided, yes, this is the body, but perhaps it's not.
And the extraction of wisdom teeth is only performed in mandible, not in maxilla.
It's not obligatory to do it in maxilla because of surgery, but sometimes they extract also upper teeth because they don't have antagonist. But for surgery it's not needed, yes. This is the example of a panoramic X-ray. Then we faced also the resorption of the roots, but we go on. These are the ceps. Of course, skeletal relationships are set on the first cephalometric, on the first lateral cephalogram. But as I told you, we have to check the decompensation, we have to check the position of upper and lower incisors, and it is done on these cephalograms before the surgery. Sometimes there is one cephalogram, sometimes there are 2 or 3. And when the position is okay, and when the transverse planes are okay, then the patient is ready for surgery. This is PA. These are a CT scan, and sometimes we print them, but in only asymmetric cases. We
You
need
print it at the dental clinic or some technical
We will start
faculty?
to print it at dental clinic, but we send the files to one laboratory.
Mm-hmm.
We needed 5 years that the CBCT for some indications is included in national health insurance. So the patients do not pay. We check also the occlusion. We do it by study cast models, and sometimes it's very rarely that we do the study cast models before the surgery only once. We usually do it 2 times, 3 times. We check the occlusion. If the occlusion is not perfect, we do the grading, selective grading. Sometimes we put the study cast into the articulator and check the movements, and also do some adjustments. After surgery, 4 weeks, we do not do anything. We just put the elastics to do the post-op immobilizations. The direction of the elastics depend on the result of the surgery. Sometimes it's not important, just to be symmetrical and to do the vertical closure. Sometimes we do asymmetrical class 2, class 3, class 2 box, class 3 box elastics to get the proper results. And we do it after the surgery, and that's why it is important that the orthodontist sees the patients when the patient goes home, and sometimes it doesn't happen. For example, this is the patients where the things didn't go well during the surgery. It was well prepared, but after the surgery there was quite a big open bite. The maxilla went up and down and up and down. It was a cleft patient. There was asymmetry after the surgery. You can see the discrepancy between upper and lower midline. No occlusion in posterior region, no occlusion in anterior region. And we needed quite, I don't know, 3-4 months to get this occlusion after surgery. And this was at the end of the treatment. So it's not always like this after surgery, but it's very rarely like this. So. This is the lady where we performed the orthognathic surgery because of the chief complaint. But here perhaps I would need some more knowledge in diagnosis of body dysmorphic syndrome or diagnosis any other mental conditions, but fortunately here it was okay. But if there is a body dysmorphic syndrome, the lady wouldn't be satisfied even after the surgery. She was beautiful before surgery, and she was beautiful also after the surgery. And she thinks that her mandible is now much, much better. Great. Profile, there are changes in the profile. Actually, I'm very proud of this case because it was difficult to perform the preparation. Even if usually the people says, oh my God, what are you doing there? This is possible only at clinic. In real life, this is not possible. A lot of X-rays before we get the right inclination of upper and lower incisors. And retention. For transversal plane, we do the upper plate, but to retain the relationship in sagittal and in vertical plane, we use positioners or Frankel appliances positioner is better, but patients usually don't like them. But this lady was motivated. And they changed one night plate, one night positioner, and so on. This was different. Cleft patients, complete unilateral cleft lip and palate. She was 25 years old when she came into our clinic. Usually we check patients with cleft at the age of 5, but she didn't live with her parents, and so when she started to work, she decided to have also her teeth done. And we did the preparation. We worsened the profile before the surgery. This is just after surgery, 3 months after surgery. 1 year after, there was slight relapse. But still okay. She lost some weight, and she looks great. Can you see here the preparation was not so as I told you before. There was too much inclination of upper jaw, but there was aplasia of second lateral incisors. The cases were very difficult, and in such cases it's difficult to get completely correct the position of upper and lower incisors. Can you see? Perhaps now you can judge. You could move a little bit more maxilla forward. But that's life. This is the case. We did quite a remodelation of upper arch. It was not expansion, but remodelation. And at the end, with the same slide as almost at the beginning, I think that a good cooperation, a good friendship between orthodontists and surgeons and the patients is needed from the beginning, from the decision until the end. And also we recall these patients at least for 3 to 5 years after the surgery. Sometimes there are relapses according to the procedures. Sometimes it's okay. So thank you very much for your attention, and it was a pleasure for me to be here.
Are there any questions for Professor Drevenšić? Everything is clear, so we've performed a lot of time, so we know all about it. Yeah, I agree. It is very difficult to treat patients with skeletal malocclusions, or to say whether to start with orthodontic treatment or to start with decompensating and preparing for surgery. And sometimes we also tend to say patients, okay, let's level and align, and then we will decide whether to go with surgery or with extractions and decompensation for the surgery, or shall we start with decompensation from the start?
This is, I think, a very important question. For example, before prepubertal peak, it's so difficult to decide if we are able to compensate or we are not. It is also very important in treating cleft patients. Usually in cleft patients, about 1/4 of them go under orthognathic surgery, 1/4. But even in non-cleft patients, it's very important to decide at the right time to compensate or not to compensate. Because sometimes you do a good occlusion, but the profile is really not okay. And there is too much protrusion. For example, in upper jaw, there is a tendency for recession, not very good aesthetic result. But it's so difficult to predict the growth before the peak. And nowadays, and when I was younger, I really wanted to know everything after the first set of after the first visit of the patients or first sessions of the patients. But now if I cannot decide, or I level the teeth, or I just say, please come in 1 year, and then I will decide. Because you can do the compensation even after the growth is ended, if the growth is okay. Yeah. But there are not strict guidelines when to do the orthognathic surgery. I keep asking people who are doing orthodontics with cleft patients, how and when do you decide to compensate the case or to do the orthognathic surgery? No answers.
So again, no answer.
No answer.
No answer.
No.
I don't know whether you saw, there was a patient today, a fetter, with the mom. She had a class 3, maybe reverse overjet of 5 millimeters, and the chief complaint was ectopic canine in maxilla. I didn't even notice this ectopic canine, and she's 13. Yeah, and the question was, shall we level and align in the upper arch? Because really there was not enough space to put the canine in the arch, and whether to decide to extract 2 premolars in the anterior in the upper jaw and to decompensate the crowding that she has. Well, she's a class 3. She will be. She's on surgical case. Do you perform in such occasions? So just decompensate the crowding and
Yes,
let them.
Yes, yes.
Without doing anything
Without
in the
doing
lower jaw.
anything. Because sometimes it's this psychological problem so big, or the chief complaint so strong, and it's difficult to leave the girl, the patient, with or 2 ectopic or 1 ectopic canine going around for another 5 years.
Yeah.
So we do the extractions or we do the leveling, and then she or he comes back and prepare her for orthognathic surgery. Yes.
Because her soft tissues or fat tissues made some camouflage, and
Yes.
also her mother is progenic, had a progenic mandible. Do you recall? So it wasn't so big problem for them. The whole family is like Habsburg family, so they know how to live it with the mandible, but the ectopic canine really.
Yeah. No, we do it. Yes, we do it. I showed the girl when we did with sprinkle appliance very short treatment of arterial crossbite, but her father had a strong chin, her father, and that's why I was really aware of doing it earlier. But then I talked to father and said, yes, she inherited the chin from you. You also have such a strong chin and mandible. And he said, no, this is not true. She's the only one with strong chin in our family. Okay. That's true.
Okay.
Sorry, just shortly, because you have a lot of experience with this.
Could you assess the lecture, please?
Like, is this something about the rehabilitation of the patient? How does he feel? Because
Yeah.
how long when he's not going to work? How does it like?
Usually patients do not go to school or to work for 4 weeks. 4 weeks, because they are swollen. There is edema, sometimes quite big, sometimes some colors, also blue and green. And the edema needed till 3 to 4 months. Some studies also claim 6 months to go away. But to go to work or to school 4 weeks is not enough. Then 4 weeks they are on not liquid but very, very soft diet, and plenty for immobilization. So it's difficult to go outside when you cannot talk or because you are not allowed to move your feet. Pain is not the problem. Pain is not the problem because if the surgery is performed not traumatically, there is not a lot of inflammation. Sometimes there is inflammation of screws, of immobilization screws, sometimes of the gums, because oral hygiene is quite difficult after the surgery. But usually the pain is not the problem. But they are prescribed painkillers, especially these non-steroid antiedemantic painkillers. But sometimes there are some psychological problems because they have difficulties to accept themselves after the surgery. Especially they go to the hospital healthy, but they came out completely broken with the edema, with the pain, with different look, and they don't know what to expect after the edema goes away. So this psychological preparation should be much stronger. At the moment, we orthodontists and surgeons prepare the patients, but there is lack of knowledge. There is lack of knowledge.
Do you do, se to kaže predviđeno?
No, možete
Prediction.
Aha, ok.
Ja samo...
Da se ne lažemo.
Prediction sa slikama da pokažete pacijentu kako bi izgledao nakon kirurgije.
Ja, da.
Radite to isto?
Samo sam se ja bala da bi me profesor Špas zamolio da pričam ja na hrvatskoj. To je zabavno.
Jer to je Slovencima, ono, samo ne na hrvatski, mogu i na francuskom, nemoj me samo na...
Bila sam na Visu i poručila sam sok i kažem kuzarac suka. I ova kelner kaže mom mužu, pa što ona želi? Čašu soka. Čašu soka. We have computer programs, VTO, where we can show the prediction of those jaw movements, but the predictions are not exact.
No.
So this is the tool how to demonstrate the patients. The best tool is to demonstrate your previous patients, what you did. And sometimes I also ask the patients who went through the procedures to talk to the patients who decide, who are in the process of deciding. And then I talk to them at least twice. When I decide to do the orthognathic surgery, I talk to them twice, and we went together also to see the surgeon. And the surgeon again tells the risks. There is risk of inflammation and there is risk of impaired sensibility of mandibular nerve. And it's, if you see, if you read the literature, the percentage of irreversible damage of the nerve is quite high, sometimes of 10 to 20%. But in our cases, we didn't make the analysis of data, but sometimes it's needed more than 1 year to get sensibility back. But we do have some cases where there is irreversible change of sensibility. And this is not okay, because you cannot feel. But sometimes the patients are so satisfied with the look, they don't care about this.
What do you do for the therapy for the
I send them to the surgeon. I say, talk to him. He did it.
I just aligned the teeth.
And at this time I say, he is the boss. They did B complex therapy, vitamin B complex. They put them into the hyper oxygen, kako se kaže, hiperbarična komora sa kisikom. Yes. Da, možda soft laser sad.
Jedino odličenje.
Well, in the surgery, any orthodontic teeth movements are allowed after 1 month.
After 1 month you can do anything you want.
There is no restriction about you must do this movement.
No restriction.
Because you had like unfinished teeth, so you
Yes. Quite a lot of work after the surgery. Yes. No restriction. Okay.